From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hi, I'm Dr. Sharlene Day. I'm an associate editor for translational medicine for JAMA Cardiology. And in this JAMA Cardiology author and editorialist interview, I'll be speaking with Dr. Luis Lopes and Dr. Senthil Selvaraj. Dr. Lopes is an associate professor at the Institute of Cardiovascular Sciences at the University College of London and corresponding author of the article titled Prevalence, Cardiac Phenotype and Outcomes of Transthyretin Variants in the UK Biobank Population, which is now published in JAMA Cardiology. Dr. Senthil Selvaraj is an assistant professor of medicine in the Duke Molecular Physiology Institute and the Division of Cardiology at Duke University Medical Center. Dr. Selvaraj composed an editorial for this article entitled Genotype versus Phenotype-Guided Approaches to Improve ATTR Detection, which is also published in the current issue of JAMA Cardiology. So I'll start this with you, Luis. Can you please walk us through the design and major findings of your study?
Hi, sure. First of all, let me just thank the opportunity to JAMA Cardiology, to yourself and the editorial board. So our main goal was to test the prevalence in what is probably the genotype first approach to test the prevalence of TTR variants in general population, and to test also the associations of the presence of those variants with cardiac phenotypes, outcomes, and the findings in terms of diagnostic codes associated with amyloid in this population. The main findings in this cohort study of nearly 470,000 participants were a prevalence of around 1 in 1,000 carriers of likely pathogenic or pathogenic TTR variants, as expected, mainly driven by the very well-known V142I variant, but also with maybe an unexpected, slightly high prevalence from other variants as well. We did detect relatively low disease penetrance, which we can explore and discuss later, but very importantly, some cardiac expression in terms of ECG and imaging for these genotypes, and also associations with outcomes, including conduction disease, incident heart failure, and importantly, all-cause mortality. But we can detail all these findings, I think, throughout the discussion and the podcast.
So Senthil, let me turn to you. Why don't you tell me what you think about the strengths of a genotype first approach are, like were used in this epidemiologic study?
Well, thank you, Sharlene. And first, thank you so much for this opportunity to discuss this important work by Drs. Ong and Lopes and colleagues. One thing that I think this study highlights is the ability for a genotype of first approach to identify at-risk individuals, ideally before the advent of disease. Secondly, it allows an opportunity to invite these individuals, once they've been identified, into potentially specific clinical care strategies, which they might undergo some periodic surveillance with a group of multidisciplinary individuals who have different expertise in amyloid care. Again, trying to identify early inflection points in the clinical trajectory and the penetrance for amyloid phenotypes. I think the third, and this is a really important point, is that it has the potential to reduce the risk of health disparities and referral bias. We know that individuals who are seen in clinical practice have different socioeconomic status, for example, than those in the community who aren't referred in. And so by identifying individuals at large using a genotype first approach, we will more broadly identify people who are at risk for developing amyloid and potentially plug them into the care they will need. And finally, and this is the goal of anything we do in medicine, is to really identify individuals who might benefit from an early treatment strategy to reduce their risk for developing clinical disease. And so the hope here is that if we can identify individuals who are at risk, who are carriers for one of these variants, that we can, one, screen them clinically for amyloid penetrance, but then understand whether they might benefit from some of the novel therapies that are currently out there or on the horizon. One example of a study that's ongoing right now is the early study with acoramidis, soon to launch, I should say, that is trying to understand just that. If we treat patients earlier who are at risk for the disease, who are carriers, can we abort disease progression and ultimately improve morbidity and mortality from the disease process?
I just want to pick up on one point that you made about referral bias, because we think about referral bias when we're looking at studies that come from individual centers where patients are referred in and may not be representative of the general population. But I'd like to ask Luis here about the distribution and diversity of individuals within the UK Biobank, because obviously there is some implicit bias as well, in who's represented in the biobank.
Sure, that's a very important and excellent point that has been also discussed in other work based on the UK Biobank, which is, in summary, a population cohort followed prospectively of 500,000 individuals, which were enrolled between 2006 and 2010 at first. But the first bias, I would say, would be that the baseline assessment is done between 40 and 69 years of age, which might influence some of the findings based on this population, including, for example, some of the penetrance or association with disease codes that we found in our study, and we can explore that later. But also, aside from these demographics, there is also a clear bias in terms of ancestry. Around 95% of the participants that we studied are of white ancestry, and that can clearly also constitute a bias. And it has been discussed before that, for example, GWAS studies based on the UK Biobank population might not entirely apply to different populations with different ancestry constitution. And in general, one might argue that the volunteer participation in this study might also introduce a bias in terms of maybe selecting more healthy individuals prone to participate in this type of study, and maybe even with a certain socioeconomic bias.
Right. Well, thank you, Luis. I think that's very accurate. Obviously, a lot of strengths of this enormous biobank that's so rich in data, and also some of the limitations that are all being addressed in development of additional biobanks. So, Senthil, tell me about what you found to be the most novel findings of the study compared to others that have been published in the field.
I do find that these results are powerful. And one of the large strengths that Dr. Lopez was alluding to is that this is a less selected patient population and is not a referral cohort. And so, in my opinion, this is one of the greatest strengths of any of these population based studies. Second, it also allows us to study variants aside from B142I, which is one of the most common variants in the world, and to take a look at other variants that have a mix of neuropathic and cardiac manifestations. For example, T80A was one of the ones that really drove some of the associations that we were seeing in this study. Thirdly, this is a large study of hundreds of thousands of individuals and so many cardiac MRI data that it's tough to think of another database that would have such a rich data set. And the linkage to ICD codes as well in this very large population allows for a greater power to detect disease associations with the variants. And finally, I think the concept that the authors showed in the last part of the results section is the importance of refining the phenotype. And so initially, if we take sort of a narrow approach to defining ICD codes for amyloidosis, we find that the variants are associated with them. But if we increase the disease manifestations and thinking about carpal tunnel syndrome and spinal stenosis, we greatly increase the number of people who potentially have the disease.
So, maybe you can delve into a little bit for us, Luis, the difference in the outcomes between the valine 142 isoleucine individuals versus individuals who had other variants in TTR. As you know, most of the prior studies have focused on valine 142 isoleucine because, at least in the US, that is the most common variant derived from Western African ancestry. So maybe you can talk to us a little about differences that you found between carriers of the different variants.
Sure. So that was one of the most interesting findings while we were analyzing the data and looking at our results. Because indeed, as you say, most of the literature out there is about V142I, including association with outcomes such as heart failure and mortality, which to some extent we did reproduce. But there was little about other variants, including, for example, the threonine 80 alanine variant and others that we analyze in this work. And we did a Cox proportional hazards analysis controlling for age, sex, BMI, hypertension, dyslipidemia, diabetes, smoking, because we have observed a difference in these common cardiovascular risk factors between the individuals and participants that had likely pathogenic variants versus the ones that didn't have. So this control was necessary in the analysis. And when we did this, we found that for the global likely pathogenic variants, including the well-known V142I, there was an increased hazard ratio for heart failure of around 2.7 and conduction disease nearly 2, but only for known Valiant 142I, we did observe an association with all-cause mortality with an hazard ratio of around 2. Also, in terms of the phenotype, we did observe increased left ventricular mass and increased maximal wall thickness only for the known V142I participants. But indeed, those were sort of new and surprising results.
Great. Yeah, I think that seems like a very reasonable explanation for the differences between the valine 142-isoleucine and one that Senthil also touched on in his editorial. So Senthil, let me turn back to you. So tell me what you think the biggest challenges will be in applying these findings in clinical practice to individuals. So taking population level data and then having the individual sitting in front of you and who carries a TTR variant, and how you're going to advise them and how you're going to screen and at what frequency.
It's a really great question, and I think one that deserves a lot of thought. And so this article asked the question, what happens if we genotype a whole population at risk and follow these carriers for the development of disease? And this provides really rich data that we can extrapolate to the patient potentially sitting in front of us who is just identified as a carrier, whether that's through 23andMe, commercial genotyping studies, or cascade screening. And so we would have to figure out a few different things. One is, at what age do we begin screening? And I think this is controversial and it likely varies from variant to variant. For example, we believe that the V142I carriers develop disease later on than some of the other variants do, although I think we still have a lot more to learn from that. We also have to think about the follow-up cadence. Do we see them yearly? Do we see them every other year? Does it vary based on when we start screening? We have to think about the type of surveillance. So is that going to be biomarkers like NT-proBNP or high-sensitivity troponin? How are we going to incorporate cardiac MRI and PYP scanning? And all of this needs to be done in the context of buy-in from regulatory, federal, and insurance stakeholders, of course. So thinking about before a relative develops disease, and then thinking about if we don't have a relative who develops disease, when do people become at risk? That age is probably somewhere around 50 or 60, and again, will depend on the variant, but that seems to be a reasonable time to bring people into clinical care and think about it, probably at least yearly follow-up in that stance. If we do this and think about expanding genotyping for patients more broadly, it'll be really important to think about equitable follow-through. So again, we don't want to just have one population getting screened. We want to make sure that we're thinking about this more broadly with other individuals as well who might be at risk. So doing this in a way that everyone can potentially benefit.
Maybe, Luis, you can share some of your thoughts as well.
Sure. So there are still some questions I think that need to be addressed if we are to apply a genotype first population screening strategy to look for individuals at risk of developing hereditary or variant-related amyloidosis, including cardiac amyloidosis. One of the pieces of data that might be very important is to actually obtain longitudinal penetrance data, which we didn't have in this particular study. So we have longitudinal outcomes, and we have a sort of a more baseline assessment in terms of ECG and imaging for only part of the individuals for which we have all the genotype available. So I think it's quite a complex modeling work that needs to be done before going and trying to translate these results for a more public health type of approach. But I think if I had to summarize in one sentence, the findings or the main message of these studies is that it does emphasize the need for clinical vigilance in individuals that are at risk of developing transthyretin amyloidosis and that have a genetic substrate for it. And also that these individuals are not so rare in the general population, with outcomes that are quite significant, including mortality.
Oh, great. I think that all three of us agree that it is very complicated indeed to think about population screening, but maybe, as you said, Luis and Senthil, with more longitudinal data where we can maybe focus on specific subgroups, and the timing too is really critical because there's a long latency period between the detection of these variants often and clinical disease, and so that's a major hurdle as well. So, Senthil, what about wild type TTR amyloidosis, right? We're not going to catch individuals who are potentially susceptible to developing wild type amyloidosis, by a population genetic screening approach. And so, are you aware of any efforts or conversations around phenotypic screening for TTR amyloidosis? And if so, in which populations might you consider that?
Yeah, and so we believe that wild type is, more common than variant-related ATTR. So that is a really important point, that even if we pick up all these individuals who are at risk and who are carriers, we're still missing potentially the bulk of individuals who are going to develop cardiac amyloid or systemic amyloid. And so from other studies, we do know and we've seen that wild type amyloid is highly prevalent, or fairly prevalent at least, in individuals with heart failure with preserved ejection fraction, individuals who are undergoing TAVR, individuals who have undergone carpal tunnel surgery as well. And so those are, in my opinion, clear populations where we really need to ask the question, even if they're presenting with one phenotype, is it a masquerader? Are we missing something else? There have been nice risk scores that have been developed as well. For example, in heart failure with preserved ejection fraction, thinking about how we can identify individuals who actually have underlying amyloid instead of your garden variety heart failure with preserved ejection fraction patients.
So let me ask each of you to comment on my final question, which pertains to the use of genetic ancestry versus the use of self-identified race and ethnicity. And as you both know, these variants often cluster in certain regions of the world. And so with this particular study, Dr. Lopes and colleagues used genetic ancestry, which was inferred from principal component analysis from the genetic data. In other studies, like some that have been published by Dr. Selvaraj, we've used self-identified race ethnicity. So maybe you can each discuss what you think the advantages and disadvantages of using either and what we should be doing moving forward.
Sure. So I believe in this type of study where for some of the associations we have explored with variants in TTR, and also where we know that one particular variant is so massively prevalent in subpopulations with a certain ancestry, I think it makes much more sense to use genetically based ancestry, where we use the standard state-of-the-art approach to get those ancestry data from the genotype data that we had available. I think self-reported race or ethnicity might have its place in slightly different types of research, including research looking for discrepancies or biases in terms of access to healthcare. So basically, I think both have its place, but with this type of design, it was, I think, the right option at the end to look for genetic-based ancestry rather than self-reported race.
So Senthil, let me turn to you.
Thank you, Sharlene. This is a really important question. And I think to try to start to do justice to this, I refer our listeners as well to a very useful consensus report that was published last year by the National Academies of Sciences, Engineering, and Medicine that takes a long, deep dive into population descriptors, such as the social constructs of race and ethnicity, and differentiating this from genetic ancestry. And so, just to underscore some of these concepts, we know that race is a socio-political construct that really shouldn't be conflated with ancestry. In some circumstances, again, depending upon what the study question is and what the purpose of the report is, race might be the more accessible identifier to help determine at-risk individuals. Sensitive methods to detect populations at risk is important. So thinking about race, in addition to geographic ancestry, might be accessible identifiers to help determine at-risk individuals. And in individual studies like the one that Dr. Lopes embarked on, genetic ancestry is likely the more appropriate identifier in this context.
I am Dr. Sharlene Day. I've been speaking with Dr. Luis Lopes and Dr. Senthil Selvaraj about transthyretin genetic variants in the general population that cause cardiac amyloidosis. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks so much for listening.